Okay, so hello everyone. This is Dr. Makos, and this lecture we are going to learn about diseases of the integument, which is essentially the skin and the accessory components of the skin, so like hair and nails. But we're really going to focus mostly on the skin. So the the nice thing about skin dysfunction, I mean, it's not nice, obviously, but it's something that's readily observable and it's easily assessed. So you can physically see and you can touch, if you want to, different lesions of the skin. So unlike with cardiovascular or renal or any other system that is internal, you can't physically see that very easily. You have to kind of, it's almost kind of like a guessing game, and then you have to, run labs or do whatever it is that you need to do in order to kind of figure out what's going wrong or going on in the patient. But with skin lesions, you can see it, and it's fairly easy to assess. So many disorders are benign, and they tend to be self-limiting. However, some can be severe and life-threatening as well. So on the next few slides, you'll notice that this file is huge for these handouts. The reason for that is because it's skin lesions and you can see them. I pulled a lot of images to try to so you could physically kind of see what these lesions look like. And so the next few slides, I pulled these next few slides from your book. I don't want you to memorize those. There's going to be a lot of different primary and secondary lesions. I really want you to use those as a guide to understand what these lesions look like in each disease, because I'm just going to refer to like, oh, this was, there's a macule that's formed, and that you can go back to these slides to see what exactly a macule would look like. I do want you to understand the conceptual difference between primary and secondary lesions. So, primary lesions will develop as a direct result of a disease, and secondary lesions will usually are a modification of a primary lesion, or they may develop due to non-disease related activities. So, once again, don't memorize these. This is just really for you to use as a reference. These primary lesions that are provided to you, and also the secondary lesions as well. So all of these images are from your textbook. And so you can also use, refer to your textbook. But I know that some of you, or maybe not all of you, have the textbook, and so now you have these as a reference as well. I do want you to, however, start understanding about pressure injuries and everything from here on out. So those first 5 slides that had images, once again, don't memorize those. I'm never going to ask you, which lesion is characterized by, it's 1 centimeter long, anything like that. That is not the goal of what we're trying to go through here. So pressure injuries, these can be the result of any unrelieved pressure on the skin. And this can cause damage to the superficial skin, but then also the tissue that is underneath that area. There are many different factors that contribute. So shearing forces, friction, moisture, and then the occlusion of capillary blood flow that results in ischemia and then eventually can lead to necrosis is probably the most common um, or maybe more important factor that contributes to these pressure injuries, because if you don't have blood flow to the area, then obviously you're not going to be able to bring oxygen or other nutrients to that area, and then that's going to contribute to that tissue damage. But the friction, moisture, and shearing forces can also contribute to that damage as well. So, a decubitus ulcer, which is also known as a bed sore, is when an individual lies or sits in one position for a long time. So, we're not talking about, oh, I've been sitting at my desk chair for like an hour, I'm going to get a bed sore. we're talking long time as in, days and weeks, not just minutes and hours. Although sometimes when you are sitting for a while, it does feel like, you may have maybe some aches and pains. So, some risk factors for pressure injuries are numerous. So, a lot of patients that you're going to see that are bedridden or that are in the hospital for a prolonged amount of time may be at risk for a pressure injury. So, lying in bed without changing position or relieving the pressure over an extended period, lying for hours on hard imaging and operating tables. So, hours as in, some surgeries take up to 12 to 16 hours. And the areas that are going to be at risk are the areas where you have the kind of over bony areas. So the heel in particular, tailbone, elbow, shoulder, back of head, if when you're laying on your back, if you're laying on your side, the ankle, knee, hip, shoulder, and even potentially ear, or if you're sitting in a chair. These are just areas that are kind of, areas of skin that are over um, bony areas of the body, and usually in some instances, there's not necessarily a lot of fat to kind of um, give some padding for that skin in that area. So the heel, tailbone, when you're laying on it directly, can lead to some pressure as well. Um, yeah, so once again, especially the operating tables and the imaging tables themselves, if you're laying in a bed, you have like even a mattress pad that's going to give some relief. But laying on that hard imaging or operating table, there's really no padding there, so that's why laying on those for a shorter amount of time can lead to the risk for developing a pressure injury. There are a lot of chronic diseases as well that can, increase the risk for developing a pressure injury. So anemia, any injury that, or disease that is has anemia, edema, renal failure, malnutrition, sepsis, urinary or fecal incontinence can increase your risk for developing a pressure injury. Coarse bed sheets as well. So when a patient that is bedridden or in the hospital and they are kind of confined to the bed, you may want to turn the patient. And so to do that, you use bed sheets to help turn them. And if they're very coarse, that can kind of lead to that shearing force that may contribute to these pressure injuries. So another thing is that individuals that have darker skin are also at risk. It has nothing to do with pigment. It's all about because the early signs of that skin damage may not be easily visible. So if you have darker skin, you may not necessarily be able to visually see that, oh, this person's heel is starting to develop a bruise, and this may be indicated of a pressure injury. And I'll kind of show you what that looks like on the next page or next slide. So, stage one is a non-blanchable erythema of intact skin. So you're going to see it's there's no break in the skin, but it is inflamed. You're going to see kind of a bruise develop, and that's this right here. If you have darker skin, we may not be able to see that bruise as it is forming. So stage two is when there is a partial thickness skin loss. This is going to involve both the epidermis and maybe even down into the dermis as well. So stage one, no broken skin. Stage two, the skin has broken. Stage three is there now that there is a full thickness skin loss, and there's going to be this damage may go all the way down to the subcutaneous tissue. You may be able to see some adipose tissue as well, which is right here. So this is fat. And then stage four would be a full thickness skin loss with damage all the way to the muscle or the bone or supporting structures, depending on where the the pressure injury is occurring. So these are, the different stages. So obviously we're trying to, keep in mind what is happening with the patient and know whether or not they're at risk for developing a pressure injury, because clearly, and obviously also if we start to see, indication of stage 1, maybe try to prevent the progression, because once you get to stage 3 and stage 4, those are, well, even stage 2, it's an open wound, so it could lead to, an increase in likelihood of infection, and many other detrimental things as well. There are also a few other types of pressure injuries that aren't exactly stageable. So unstageable is there's full thickness tissue loss. But the base of it's covered, so you can't exactly see it. So that is why it's considered unstageable. So it's covered with an ulcer, or the ulcer is covered with slough, or maybe a scab, or both in that wound bed. So you can't really see the full what stage it's at. So this could be potentially stage 2, it could be stage 4, but you really can't tell just based on the presence is kind of blocking your view of how deep that pressure injury goes. There is also a deep tissue injury, or sometimes it's also called a suspected deep tissue injury. So there is, it's a localized area. It's generally a deep red or purple or maroon, a very a kind of brightly colored um, discoloration of the skin. And this there could be a blood blister, or it could be just some kind of indication that there may be a full thickness pressure injury here. So, for skin injuries, you can kind of only guess what's going on underneath the surface based on what's happening on top of the surface. So this may be an indicate this brightness in color may be an indication that there is a full thickness deep tissue injury occurring. However, there has been no necessarily breaking of the skin with this deep tissue injury. So there's a lot of different scales that are used, or metrics that are used to predict pressure injury risk. The Braden scale is most often used, and I believe that is what it's what your textbook uses, and what kind of we were just discussing right now. But there are others as well. They are certainly updated. You know, as often as they need to be as we learn more about pressure injuries. So definitely I would like you to know not the full difference between understand stage 1 through 4, and know that a deep tissue injury, or a suspected deep tissue injury, what that is, and then also how this why this type of injury would be considered unstageable. And then also some of the risk factors and causes of those pressure injuries. Now we're just going to briefly touch on keloids and hypertrophic scars. I know that you went over these many weeks ago, and when you discussed inflammation and wound healing, but just once again touch on them a little bit. So keloids are firm, elevated scars, and they extend beyond the original site of the wound. So keloids and hypertrophic scars are similar to each other in that they are an excess of collagen production by fibroblasts. So fibroblasts in both keloids and hypertrophic scars will produce an excessive amount of collagen. Really, it depends on the type of collagen, and also the how the collagen itself is deposited, and also whether or not those fibroblasts ever stop making all of that collagen. So keloids They tend to appear after a stable scar is already formed. So the wound is healed, but those fibroblasts keep making that collagen. With keloids, they tend to make, there's usually an excessive amount of type 1 and type 3 collagen. This can lead to fibrosis, and it also can lead to a little bit of inflammation as well. So the thing about keloids too is that there's no spontaneous regression. So with hypertrophic scars, over time, it takes about 6 months to a year, but they eventually will subside. Whereas keloids, in a lot of cases, will just kind of keep getting bigger. They tend to be more common in individuals with darker pigmented skin, and following burns. However, I knew someone, they were very fair skinned and they also happened to be a keloid former. So once again, it's more common in darkly pigmented skin, but it can happen in anyone. If you do find that you develop a keloid, you are more likely to continue to develop keloids. So if you get a cut, it's more likely to develop into a form of keloid. And generally speaking, when you if you try to remove these, um, they're very likely to return. So they're very difficult to treat. Very difficult to treat. So, hypertrophic scars, on the other hand, these are also, it also has to do with excessive collagen formation. These tend to be more erythematous fibrous lesions, so usually more red, and they tend to be confined to the original site. So, you can see here in these I don't know why cartilage piercings do this. Mine did this too every single time I got one. They're just this. Um, you know, some people may mistake this for a keloid, but if you kind of look at the difference, see this is a keloid, it's very large and it'll keep growing, whereas this is fairly confined to the original site of the injury or the piercing in this case, and it won't get much larger outside of this. They tend to have a lower rate of recurrence, so it's not necessarily likely that you will form another hypertrophic scar if it's removed. There is, keloids also have rapid growth, but keloids don't regress. So hypertrophic scars will regress. So after about 6 months, sometimes a year, these eventually will go away, and kind of the skin will be, the scar essentially will be more normal, rather than enlarged. So once again, these also have excessive collagen formation and abnormal fibroblast activity. So they're really, really hard to kind of distinguish between them. Usually, it's more of a visual. Kind of a visual take, but there has obviously been studies to kind of determine the difference between these. I pulled this from a paper. So sometimes I think it's kind of nice to look at them side by side. So keloids tend to have constant growth. So you have your injury and then they just kind of keep growing and growing. They don't regress, they just keep growing. They may grow slowly, some grow a little bit faster than others. They extend beyond the margins of that tissue damage. So, the tissue damage was, superficial here, yeah, whereas, these are large, kind of bulbous growths. That's kind of what that means by extending beyond the margins. Um, One thing to notice too is that when the collagen is deposited, it's not deposited in a very orderly fashion. It's kind of all over the place. So these like thick kind of jumbled bundles of collagen, which is what gives it that kind of enlarged and puffy shape. Whereas with hypertrophic scars, they grow fairly quick, but they regress almost as quick as they grow. Not really almost as quick as they grow, but they regress in 6 to 12 months. The collagen fibers that are deposited for a hypertrophic scars, instead of being kind of all over the place, they're deposited in the nice parallel sheets, parallel to the skin surface. So that may be another reason why they also kind of will regress, because the nice evenness of how that collagen is deposited. So, this is kind of hopefully to try to help you to understand the difference between keloids and hypertrophic scars. I know there's a lot of people I know that think when they have a hypertrophic scar, they think, oh my gosh, I'm a keloid former, but really, they just have a kind of an enlarged scar. So hypertrophic meaning, remember, increased growth. So that scar is just kind of larger than it normally would be. So probably the two things to kind of take away from this is that the way that the collagen is deposited is differently, and then also the whether or not the scar or the keloid regresses. So to me, at least, those are the two kind of things that really help with distinguishing between the two. So moving on to pruritus. Pruritus is itching. So this is more of a very common clinical manifestation of a lot of different skin disorders. So itching itself, isn't necessarily, well, there's not really fully understood what pruritus is. I mean, we know obviously what itching is, but there's a lot of different types of itch. I guess if that is kind of, a strange thing to think of. Certainly there is acute versus chronic. So acute, I usually think of like a mosquito bite, because that has a very quick onset and generally has also a very quick uh, lack of itching as well. So it itches a lot, really, for maybe like the first day or two, but then after that, it's pretty much done. Um, Pruritus or itching can be localized to a specific area. It can be generalized, whereas in it's like, oh, my whole body itches, or it can be migratory, is in moving to different areas of the body. There are a lot of puritogenic mediators. So think about things that make you itch. So these would be more of chemical mediators. So histamine in particular, remember, mast cells degranulate. Those of us that have allergies, when you come into contact with your allergen, so if you have seasonal allergies like me, and when the grass starts to bloom in April, like my whole face itches, everything itches, because those mast cells have degranulated and they've released histamine, prostaglandins, bradykinin, opioids as well. There's a very long list of chemical mediators that can make you itch. So, and if you notice, a lot of these as well, at least these first three, those are also involved in inflammation. So, um, um, you know, it's all about, it's not really fully understood, I guess, why we itch. Why would something that is inducing inflammation leading to an itch response? Because obviously our response to an itch is to scratch it. And if we scratch something, then especially if we scratch it excessively, that can actually lead to skin trauma, infection, and scarring. And that's not necessarily a beneficial thing. So it's not really fully understood. But we do think that you have whatever it is that's the trigger. You may have the activation of the inflammatory response, and those inflammatory mediators such as histamine will interact with these small unmyelinated C nerve fibers. And then they are going to travel to the brain, and then the brain is going to recognize that as, oh, there's something that is that is itchy in this area, and we need to scratch it. And I'll tell you this, like, as I am giving this or talking about this, I feel like everything on me is itching right now, which is very good because not really good, but it's kind of leads me into the next slide, which is itching can occur without a chemical stimulus. So the itch response is modulated by the central nervous system. So you can have the sensation of an itch without a stimulus, which is considered a neuropathic itch. So that's an itch without a stimulus. So sometimes just talking about feeling itchy will make someone else feel itchy. Um, like a funny story that once it was years ago, I got a call, a dreaded phone call from my son's daycare saying that there is a child in his room that had lice. And they said, "Oh, it's all right." Da, 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 da. But as I'm on the phone with her, I couldn't help but start scratching my head because my head started to itch just talking about head lice. And the same thing happened. I told my husband, I said, "Hey, it- and he's like, "Oh my gosh, my head itches." And so, I mean, clearly in the moments before she told me that there was head lice in his room, I was fine. But then as soon as she told me, my head started itching, and that would be considered a neuropathic itch because there was no stimulus. Um, but the sensation of that itch was definitely there. Um, it can be due to a pathologic condition, or it can be more of a psychological thing. There's also psychogenic itch, which is associated with psychological disorders. So, individuals with depression or OCD will often feel sensations of itching. And this, remember, for depression or either of these, it can be focused in one area, or it can be more of a global itching sensation, or it could also be migratory. But the itch itself, there's generally no stimulus. And so, especially with the neuropathic and psychogenic itches, because there's no stimulus, what is our first reaction to an itch is to scratch it. And so, if we scratch, that can lead to it can lead to a breaking of the skin, which increases your risk of infection. It can lead to skin thickening or lichenification, or and also can lead to scarring as well. So, and sometimes with the psychogenic itch, I happen to have a friend who has OCD, and she won't even realize that she's scratching. It's kind of part of her part of the OCD is that just one area in particular that she is constantly scratching, and it feels like there is an itch there when then there's no stimulus. So pruritus, remember, this is more of a generalized concept of itching. There are a lot of different skin conditions that will lead to pruritus, especially diseases that have an inflammatory component, because a lot of those inflammatory mediators will lead to the sensation of an itch. So I think that that might be a good place to take a break. And so let's take a break and kind of shake it out, and then we're going to get into some more specific diseases.